Getting the right care to people in a timely fashion is not a new challenge in the northern reaches of this province. Presumably doing so under COVID-19 has been even tougher. With us now on that and what might help, in Marathon, Ontario, on the north shore of Lake Superior, Dr. Sarah Newberry, who's been on the front line of COVID-19 in her practice at Marathon Family Health Team. She's also Assistant Dean of Physician Workforce Strategy at NOSM, the Northern Ontario School of Medicine. And Dr. Newberry, we're delighted to welcome you back to the program. How are you doing?
Thanks so much, Steve, for that warm welcome. I'm delighted to be here as well. Thank you.
Maybe we should just start by having you give us a sense of what a typical day is for you. What comes through the door?
Oh, yeah, that's a great question. It depends to some extent on where the clinician is on any given day. But as rural generalist family physicians in the community of Marathon, we work in our primary care setting, in our emergency department, in our hospital inpatient ward, and of course, with COVID-19, we work in our assessment center as well. So what comes through the door depends to some extent on where we are, but certainly we see all kinds of presentations in primary care. We see the full gamut of presentations in our emergency department, from motor vehicle collisions to heart attacks to COVID-19 presentations. We manage many of those things in our inpatient ward at the hospital. And in our assessment center, we see everyone who has symptoms that may be consistent with COVID-19, and we do our assessments and swabs in that setting as family physicians and as part of the team.
Just by way of comparison, if you were a GP in Ottawa or in downtown Toronto, would you be seeing the same kind of stuff come through the door, or is what you're seeing different?
Well, I think in the office setting, Steve, absolutely. What we see in our primary care community practice is very similar to what family physicians see across the province. We do a lot of preventive care. We see people with chronic disease, so diabetes, hypertension, heart disease, cancer. All of the things that we see in our community-based clinic is what would be seen in most family practice settings across the province. What's different about rural settings actually is our involvement in the hospital, our presence in the emergency department and our inpatient unit, and certainly our interaction with the assessment center, which is really well integrated with our primary care setting.
Now, obviously, a lot of people in, say, Toronto or Ottawa, Mississauga, Hamilton, you know, they may have a 15 to 30-minute drive to see their doctor. How far do people have to come to see you?
Well, it's interesting. Marathon is quite a densely populated small community, but we also serve two Indigenous communities, the communities of Bigtugong First Nation and Netmazagamig First Nation. And for them, they are driving between half an hour and 50 minutes to come to be seen here. We also go to those communities to provide satellite clinic services there to minimize the travel for people who live in those communities. But for anyone from the area who requires surgical services, who might have a higher risk obstetrical case, who might need chemotherapy or radiation, they are having to travel to Thunder Bay, which is most days a 4-hour drive away.
Wow. All right, one of the things that we're trying to consider on our program tonight is, you know, we got this report from the Financial Accountability Officer saying that we're, going to be upwards of 500,000 surgical and diagnostic backlog cases as a result of COVID-19, because the healthcare system, of course, has had to focus so much on that a lot of other things got left behind. And we're trying to figure out how to deal with that. And one of the ideas that's come forward is that perhaps privately owned healthcare clinics, still could be not-for-profit, could be introduced into the system as a way of trying to deal with that backlog. And I'd like to get your take on that and whether that is an option for your part of our province.
I think that's a really great question, Stephen. I think privately owned and publicly funded centers may have a role to play in terms of decreasing the surgical backlog in particular. I don't know that that will have a huge impact in rural communities across Northern Ontario, but certainly I think we do have a role to play in our rural communities to optimize the way in which we receive patients back from our tertiary centers so that we can offload the work of our tertiary centers as much as we can, so that all of the resources that we have to deal with the surgical backlog can be applied. It would be a rare rural community that would have a surgical facility, and so the impact directly in communities would be very limited.
In which case, Is it the case that you just don't have the population there to support the potential work of a clinic like that?
Yeah, that's exactly right. So, a community like Marathon, we have a population currently of about 3,500, and then the Indigenous communities that we serve and support here. We do run cataract surgery through our hospital, and we have a colonoscopy service, but those services are really only a couple of days a week and are actually well integrated into our hospital setting. The population base that would make a publicly funded, privately run facility make sense really doesn't exist in a community of our size or in this geography in particular.
Since you mentioned hospitals, let me follow up on that because, of course, over the last many years, we have seen, well, there have been a lot of hospital closures in rural areas across North America, remote areas as well. How much of this is happening across Northern Ontario?
It's a really good question, Steve. Well, certainly in the United States, there have been a significant number of rural hospital closures, roughly 125 in the last decade. We haven't seen rural hospital closures specifically in Northern Ontario, although we certainly have seen a decrease in some services. Obstetrical care services in particular have decreased in rural hospitals. And there has been an increase in the use of locum services to sustain emergency department coverage across the north. And that's certainly something that we've seen increasing over the last several years.
And for those of us who aren't great at Latin, locum services means what?
Right, thank you. A physician who fills in on a temporary basis. So historically, it might be that if I was going on a vacation for a couple of weeks, I would have a physician come and replace me for a couple of weeks to provide care to my patients in my absence. What we're seeing now across Northern Ontario is an increase in those fill-in physicians to cover emerge shifts, sometimes only 1 or 2 shifts at a time, simply because the local physician capacity to do all of the work that needs to be done in primary care, hospital inpatient work, emergency department, and the assessment centers, that local physician capacity is diminished in many of our communities, and we rely much more now on external physicians coming in to provide short-term coverage to keep services open.
Does that necessarily mean that the service is worse because they're not from the area and perhaps don't know the patients as well as a local person would?
So certainly what I think is that the physicians who are coming to provide that care are excellent clinicians. To your point, though, there are issues about the way in which we deliver care. Often in a place like Marathon, that means how do you navigate coordinating a transfer of a patient from our emergency department to Thunder Bay Regional? And certainly, if you've got some on the ground knowledge of the way that the system works, it's much easier to do that work fairly seamlessly. And certainly, having a knowledge of the population, having a knowledge of individual patients can help us to deliver high quality care as well. And the other thing, Steve, that I would say is that when a physician is coming to fill in for another physician, they're generally here to do the clinical work. They're not here to do the policy work and the system support work that is part of what it takes to create a high quality healthcare system that is focused on creating access and delivering high quality care for the whole population. And so the more that we have clinicians in the community who've made a commitment to comprehensive care and continuity with that community, the more highly functioning that local healthcare system can be.
Sure. And I assume that's what NOSM, the Northern Ontario School of Medicine, is all about. If you're trained in the North, you're likely going to stay and practice in the North. Fair to say?
That's absolutely right. And 2 specific populations that have particular needs that are a focus of NOSM's education are the needs of Francophone citizens and the needs of the Indigenous population across the North. And NOSM has a particular focus on how we care for those populations. And I think our graduates come out of their training with a particular sensitivity to those populations and their specific needs.
Gotcha. All right, let me come full circle now and get back to that notion put forward by the Financial Accountability Officer that we have this multi-hundreds of thousands of backlogs now of non-elective surgical and diagnostic procedures, which I presume is manifesting itself in Northern Ontario as well. Have you got an idea or two you could share with us as to how you think that backlog could be tackled?
Well, I think from my standpoint, Steve, I think we have a huge opportunity to ensure that we are resourcing and creating capacity in our rural communities so that wherever surgical capacity exists in the system, we're able to use When I think across northwestern Ontario, for example, we have excellent general surgeons in Sioux Lookout, in Kenora, in Dryden, in Fort Francis, and we need to be able to equip those communities, those hospitals and their teams to be able to do the kinds of procedures that they can do locally, because that means fewer patients having to travel to places like Thunder Bay. And then Thunder Bay can optimize the service that they're able to deliver. In small settings like Marathon, as I mentioned, we can do colonoscopies and cataract surgeries. And the more that we're able to do those kinds of procedures locally, the more we free up capacity in our tertiary center to be able to deliver the care that only they can provide. So from my standpoint, I think we need to look at how we resource and support and sustain our rural communities and our small rural hospitals so that they can participate as fully as they can in healthcare delivery for the whole of the system.
Does that simply mean more money?
It may mean more money. It may mean the way that we spend that money needs to be done a little bit differently. We've talked a lot recently about integrated care and the importance of integrating care across the system. In fact, just yesterday, there was a conversation led by Rick Glazier and Jim Rourke, who are two clinician researchers, to explore how we can better integrate care in local communities. And part of what that means is how do we better use the resources that we have, both fiscal resources and human resources, to optimize the care that we deliver here in service to patients and with patients at the center of that care. So how we utilize our paramedics in our communities, how we utilize clinic-based nursing staff to provide home and community care, how we coordinate services between hospitals and clinics so that we're really doing the most that we can with the resources that we have is a really tremendous opportunity for rural communities. And rural communities are small and they can be nimble. We can implement things quite quickly and quite seamlessly. What we need is the research capacity to understand what it is that we're doing from an evaluation standpoint and then be able to share that so that other rural communities can implement the things that are successful.
Dr. Newberry, we're always so grateful when you take our calls because we learn so much about how it works north of the French River, which, as we've heard, is often very different than south of the French. Thanks so much. Take good care, and we'll talk again soon, I hope.
My pleasure. Thanks again for the invitation.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.